I will do a brief introduction for Dr. Haskins. Hello, glad to see everybody's jumping in here. She is a retired counselor and educator who got her PhD in pastoral counseling. She's also a licensed clinical professional counselor and approved supervisor, an internationally certified gambling counselor, and clinical consultant, an international clergy lay problem gambling and spiritual outreach, and master's addiction counselor. She is the president of the Maryland Council on Problem Gambling. Dr. Haskins has trained mental health professionals in the U.S. and abroad to understand disordered gambling and provide culturally relevant services. Her expertise and publications include gambling disorders, cultural competency, and social justice attuned mental health and wellness. She assists practitioners and faith and spiritual communities with incorporating mental health delivery beyond traditional formats. Her current efforts include equipping faith spiritual communities to support disordered gambling and homicidal loss and trauma advocacy and trainings. It's a pleasure to see you again, Dr. Haskins.
It's a pleasure to be back. Thank you so much, Tana and Evergreen. I really appreciate you all.
Thank you for being here.
You're welcome. So I'm ready to get started. Thank you. I'm so excited. Want to thank the Evergreen Council and anyone who's out there for all the great work that you all are doing. I am excited to present Outside the Box therapy and hope that all of us are going to be empowered and encouraged to do more outside the box. So let's get started. The objectives include, I'm hoping today in our brief time to identify cultural and social justice model fit for persons of color and indigenous persons, because traditional therapies don't really fit well for many of these individuals, families, and communities. And then secondly, to identify what we call, and Evergreen has asked me to do, outside the box strategies for consideration in disordered gambling, but also for mental health treatment and prevention, I would add. So let's get started with why outside the box. Why is this important? When I was a student in counseling services master's training at Rider University, which is located in New Jersey, I kept wondering, how am I going to use this model or these theories, these techniques with the communities that I plan to support and serve? Specifically because I'm African descent and born in America, African American, but I descended from Africa. And I knew that people in my own culture, as visible racial and ethnic persons, would not really feel comfortable with the traditional models. But I also knew that persons of color and people who identify as indigenous persons would likely find that there's not a goodness of fit as we describe it. So I knew that if I intended to enhance well-being among more than just European descent persons, families, and communities, it would be important for me to figure out how would I make the necessary adjustments. I know from my own lived cultural experiences as a Black woman, as I said, as being of African descent, that many will not seek mental health services. Many of you you may be in the European descent communities, but depending on what your ancestry is, if you're Italian, if you are Jewish, if you're Polish, you may rely on your familiar family resources and what you feel is more native to your own experience. But particularly with many people of color and indigenous members, it becomes even more challenging. So as one of my Chinese doctoral student peer students said to me and said to our clinical class before returning to China, she says, how am I going to apply these models to a communal culture that has an entirely different worldview than Americans and Eurocentric models of healthcare? And so outside the box, as we'll talk about over the next 50 so minutes, is going to be important. So I decided before even having the concept outside the box, that I would use methods outside of the discipline. Because as I said, the light bulb went off and I said, wait a minute, there's such a disconnect. The traditional models is not going to really lend itself and really be a comfortable healthcare support and healing support for many persons of color. So what are we talking about here? And I'm going to go back actually very briefly to look at some of the, it's going kind of quickly. I don't know what's happened, maybe with the timing, but you'll see this when you get the slides, because I'll be sending this to Evergreen. But I'm not going to spend a lot of time on these because many of you have already been introduced to cultural worldviews. And I'm just going to highlight some components that are really key when we're talking about providing services to folks who experience disordered gambling and have other co-occurring and mental health challenges. But again, you'll remember that most of the traditional models in Western mental health care in particular focus on an individualistic model of help seeking and recovery. And it was, if you think back to Freud, who was European descent, bringing people in individually and using what might really make sense if you come from an individualistic model where the reliance on personal control is internal, and then the way that people may view responsibility in terms of who's responsible if something needs to change is also internal. But so the Western models of health tend to be more respected and valued within these individualistic worldview approaches. Now, when people attach to their ethnicity, it can vary even some of these individualistic cultures. So for example, one of my colleagues who's a counselor educator and professional counselor, she says, I might look visibly as a white woman, but I am Polish. And in my Polish ethnicity and identity, this is the way that we value experiences, and this is what we do when things happen. And so also, the last bullet you see is talks about whiteness and looking at privileges of, as Dr. McIntosh talks about, the unearned privileges of whiteness. If you're white, you don't have to worry about being followed in a store. You don't have to, you might have some unearned privileges just because you've been in this dominant culture for some time from birth. Now, in Black and African descent culture, which is my own culture and many cultures that also include not just American born, but people from the continent of Africa or even from the West Indies, what we refer to as the African diaspora. What's really important is the fact that slavery and slavery trauma is still ever present, and it is validated and shared in oral history. And so even though people outside of the culture may say, well, why are you still hung up on slavery? But slavery still impacts people in the current today, and we refer to as post-slavery syndrome. But many family members still are very connected to the impact of slavery, and they teach their children what that means for them. And so the oral tradition of learning and of valuing is very important. They also value the extended family networks, which include non-blood relatives. And so when they are in trouble, they seek help from people from these networks. What's really key about African culture is that typically spirit is at the center of everything. And so one of the challenges is when I started doing training in Detroit, the council director said, you know, we tend to have really good outcomes with our Black women, African descent women. They seem to be so connected spiritually, but something is very different with Black men. Okay. And so what has happened over time that moved people away from that spiritual center? And that's what disordered gambling and mental health wellness can help them with, and what I'll be talking about in terms of outside the box as well. But what's key, as you've already learned, is that many people will mistrust these Western healthcare models because they still see the legacy of slavery, marginalization, colonization, and they don't see that these institutions, including my profession, as being a place that they can really feel safe in. So that's really important. Again, I apologize, this keeps flying through. Asian descent, on the other hand, is similar to African descent and Latinx in this way that they really value the family, La Familia, but also the community. Communalism is very different from the individualistic model. And so in the Asian descent communities, everybody's behavior is also interpreted as impacting the others because you're part of a larger network of community. Shame is therefore a very strong emotion in Asian descent. And so mental illness and mental health challenges tend to create experiences of shame. And so when disordered gambling happens, people really struggle even more because they really feel not only have you impacted our family, but now people are going to view our family in a negative way. It's going to potentially harm the standing of the family. And not only that, you're impacting the collective family. And so in Asian descent culture, on the other hand, they may not seek mental health treatment because they will seek the medical professionals first. They value the expertise of the medical doctors, and so they typically will see them first. And that's why in our disordered gambling advocacy, we've had to do a lot of work to educate the medical profession because they may be the first time responders, the first line responders, if you will. Latinx, which has been some really good work being done by Dr. Patricia Arredondo, describes what are some of the key worldview. One, La Familia, the family. Machismo is a strong cultural role for men, and so they have these highly gendered patterns and expectations, and so anything that is viewed not to be masculinity, which is very similar across many cultural groups in terms of what we are sometimes even referring to toxic masculinity models, because it doesn't allow the man, whether they're in Latinx culture, to see that it's okay if my heart is hurting and I need to reach out for help. On the other hand, they have a strong value called Marianismo for women, and that is the gender role of the woman being the caretaker, the nurturer, the long sufferer. And so what that can pose for a person who is struggling to come in for help if they're experiencing gambling disorder or mental health challenges, that they may suffer long is actually seen as a spiritual virtue. And so the Latinx woman, particularly this comes out of the Catholic tradition with I'm like Mary who suffered long, and by suffering long that strengthens my spiritual identity. It is strengthening my faith identity. It's making me stronger. And so people may delay getting help because it's actually seen as a asset or a positive if I suffer long. We also have to understand that when you're working with Latinx, that you have to understand the impact of acculturation, but also trauma, which includes political trauma. And that's a whole nother workshop. And I know that you all have had a lot of different series in terms of ethnicity and culture. And I want to encourage you to keep looking for these opportunities. And you can feel free to email me at my email, which you'll see on the first slide, if you have any questions in the future. So I want to just say this, in order to understand how to provide outside the box therapy, we first have to really focus on context is everything. What do I mean? First of all, the first outside the box strategy is that you have to understand context. And what do we mean by context? We mean that the way that the person is experiencing life, their values, their beliefs, their environment, their interpretations, the messages that have been explained, the messages that are provided within the culture, which we refer to as emic, culture relevant, culture specific. We have to understand that their context, what they're experiencing, is going to color everything. It can color how they view gambling. It can color how they view depression. So for example, one African American grandmother used to say, "Sweetie, just rest your nerves. Just rest your nerves. You're not depressed. You just need to rest your nerves." And so the way that they interpret when people are sad may not be the same as people in other cultures may interpret it. And so this is why it's important to make sure that the first outside the box strategy is one where we focus on asking the question, what is the context? I have been saying since the time I entered this field as a gambling disorder leader and mental health practitioner in this field and advocate that people do not view gambling as a problem. They actually view everything else as the problem. And gambling is actually viewed, as many of you already know and are learning, as the solution. And so why is that? It's because many of these individuals as persons of color and indigenous members, they have been gambling for a long time. Gambling has been present in their communities. It was part of the culture. It's the way that we interact. It's the way that we connect with one another. In the African American community, fathers and men gambled as a way to provide for their families. They were numbers runners. And then when the legal lottery came on board, it actually made these men unemployed because they had their own entrepreneurship, which is viewed as illegal gambling now, but this was the way that they took care of their families. So understand that this is what's really key first. Think about what is the context here. And so in order to understand context, we also have to understand what are the social determinants of health and health equity. And I want to introduce you to, and I'm providing the link from one of our amazing gambling advocates and leaders in the state of Massachusetts, Victor Ortiz, and the team that he's working with in the public health department for gambling, problem gambling. And they have just published an article called Our Voices Matter. And what Victor and the research team, as well as all of us in this work, are highlighting is that there are social determinants of health that predict what is going to be potential in a person's life. And what is a social determinant of health? The CDC defines this as life-enhancing resources such as food supply, housing, economic and social relationships, transportation. So for example, in my great city of Baltimore, people aren't working a livable wage. They may have to take 3 buses to get on the other side of town just to get to their unlivable wage job. And so it's no surprise that they're gambling because they need to supplement their unlivable wage job. And that's a social determinant of health issue. But it also includes education, which we know when you have underfunded public school systems, then the outcomes of that is you have people who are undereducated, don't have the same equitable opportunities to seek occupations and take care of themselves in the future and their families. But it also includes healthcare. And so social determinants of health determine the length and the quality of life. And why is that important to understand with context? And this is the article that you can check out. It's actually not on this slide, but you'll see it listed, I think, at some point. But I also want to give you a case illustration. In understanding the fact that not everybody starts out in the same place, and there's a difference between equality and equity. Equality assumes that people start out with the same opportunities. And so you're going to have the same opportunities to engage in the world, to take care of yourself and your families, to get housing, et cetera, et cetera. Health equity says that not everybody has the same opportunities. And what we need to do is we need to provide the necessary accommodations when a person isn't starting out in the same place. And so this is an example of a health equity lens being used. One of my supervisees currently, her name is Dr. Naisha Grayman Simpson. She is a psychologist by training, a counseling psychologist, but she's presently getting her licensed graduate professional counselor license. And she has developed an acute bereavement practice focused on African American and African descent Marylanders. And you can check her out if you go to the website. I'm just going to click this on really quickly. And I hope that I'll be able to go back because sometimes Zoom is doing its own Zoom thing. um, and I'm not quite sure sometimes, but I'm going to see what I can do here. But here she describes what her grief therapy is. She includes what are some of the self-help resources. Dr. Grayman Simpson has developed a book called Seasonal Therapeutic Encounters with Nature Journal. What she does is she actually uses nature and in every session with the client in this acute bereavement practice, which is a 3-month program that is providing the client 4 days a week of healing support. And she uses a variety of outside the box therapies that include these self-help resources, giving them interventions to use in nature with guided reflections. And she actually produced a book that really identifies all these places that you can go in Maryland, but you could think of even in your own work, how you can also use nature. And I'll be mentioning that further down the road. But basically, this grief therapy with her, she also provides booster sessions for clients when they're approaching anniversaries of trauma experiences or very difficult grief experiences. So this is just a really quick example of an outside the box experience that I wanted to highlight. I'm going to try to go back to this and let me just, get started again because I'm sorry. Looks like I lost. Here we go. All right. So I just wanted to give you an example of that, but just think about what are some of the outside the box things you can be doing with your clients. Now, this is the article that I alluded to, which is hot off the press that Victor Ortiz and his team has developed. And what they did, which is an outside the box initiative, is just the recognition that there are a lot of people in our communities and also in many of these cultural communities who have lived experiences that they believe work for them. They have lived experiences and wisdom that are not necessarily being validated by the larger world outside of their community. And so what they did in the state of Massachusetts, the Division of Problem Gambling Public Health Division, is they hired these community members and made them community ambassadors, because these are folks who they are having experiences of substance abuse, gambling disorders, problem gambling, co-occurring challenges with other mental health, and they are arming these ambassadors to hit the streets, to have conversations with people in the community that understand them, that they connect with them culturally, that will listen to them. And they have been able to reach over 4,000 community members through this community ambassadors program. So this is just an example of an outside the box paradigm shift. And I encourage you to read the article when you have some time, because it will give you some ideas for outside the box. So let me just share with you what are some outside the box strategies according to Deborah Haskins. So the first outside the box strategy, and if you listen to the podcast the Evergreen provided, you will have heard of this. What I often say is Dr. Alan Ivey, who is a psychologist and counseling psychologist and works in the professional counseling field, talks about this notion of gift the client each time the client comes. And what do we mean by this? We basically approach therapy, whether it's disorder gambling treatment, substance abuse or addictions treatment, trauma, recovery, whatever it is, we want to work as if each session is the last time you're going to see the client. And why is that important? We mean, and this is what you have learned in the Evergreens core training. If you've not gone through that, they'll be starting this up again in the fall. Or if you've taken other core training for gambling treatment, disorder gambling treatment, you will have heard this, that you look at what the gambler or affected other is presenting and you try to prioritize what is needed right now in this current moment at this current time. It's pretty much using solution-focused therapy. Some of you and many of you might be familiar with. But the goal is to relieve the stress in the here and now, because guess what? I might not see you again. And so if I never see you again because you decide to drop out of therapy, I want to give you something every time you come that you can immediately use to provide some recovery and relief from whatever is troubling your heart and your soul. So I view outside the box disorder gambling treatment, prevention, and gambling wellness as this. I've been doing this outside the box approach my whole career as a professional counselor and counselor educator, training psychologists, social workers, addiction counselors, faith and spiritual members, community members for the past 30 years, basically since 1984. And so it's very important. And that then leads to this next point. One major gift that you can give your client, whether your client is a gambler, the family, the community you're serving, or if you're a preventionist, is to use patient-centered, culturally sensitive healthcare. And what is that? This is a very interesting and really paradigm shift in our profession, because Dr. Carolyn Tucker, who is a counseling psychologist down in the Atlanta, Georgia area, started this research program in 2007, and it's been replicated since that time with not just European descent, African descent, Latinx, Asian descent, Native Americans, biracial, multiracial. And the difference here, instead of asking the researchers or practitioners how we view what is client-centered, culturally sensitive healthcare or patient-centered, culturally sensitive healthcare, guess what they did? They asked the patients themselves. And because when you talk to the patients or the clients, they're going to have a different viewpoint than the researcher or the theorist. So for example, I was a consultant on a project where I was doing diversity, equity, and inclusion training, and they wanted me to look at the research scripts that they were using to recruit culturally diverse persons to their research programs. And I said, when I read this, I thought, number one, boring. Who developed these scripts? It must have been a researcher. People don't talk like this in regular life. And so I changed the scripts to make it include a regular human element, particularly for people of color and indigenous members. So this is a very important study. And so let me just tell you some of the questions that they asked them. So you'll see the client's perceptions of cultural competency, as the research team identify, is not the same as what we're going to think. And these are some outside the box questions that you can ask your clients right from the beginning. This is what they recommend. Ask your clients right from the beginning, what does or could your doctor or provider or me as your clinician or preventionist do to make you feel more comfortable? Or what are we doing to make you feel uncomfortable? What makes you trust the doctor or the provider more? What does or could your doctor or provider do to show you respect and to be sensitive to your needs? How could we show that we're respecting you more as an African person, as a person from Trinidad, or a person from Jamaica, or someone from Nigeria, someone from El Salvador, or if you're Polish, or if you're Jewish, as one of my Jewish American males came in? What could we do? How can we be better, help you, coming from your own racial or language or cultural background? What can we do better to help you? And what are some physical characteristics of this environment that could help you feel more comfortable here? So that even includes the artwork that we use. If our artwork is not culturally inclusive and all I'm seeing is European descent faces in the artwork, or artwork that doesn't reflect my culture, or say the magazines or the books that I have in the setting. And of course, now we have virtual settings. What do we need to modify to help the person be comfortable? And this could be something that you actually have your client fill out at the same time you're giving them the intake information. Ask them to answer these questions. And then what you do is you look at that right from the start, and then you make the modifications so that you can then incorporate anything that could be outside the box. But from that person's perspective, it really isn't outside the box. All right, so let me move on to the next one. Strategy 2 is not all clients can do the verbal work and processing of mental health treatment. Let me say that again, not every gambler or not every person breathing through addiction recovery or breathing through any mental health or life stress can do the work of emotional and cognitive processing. Let me just say this. And I know this for myself because I'm breathing through homicidal trauma twice. I did not understand what my client meant when my client said, Debbie, this is too hard. All this emotional, cognitive processing, she didn't say it that way, but she was saying the work is too hard. I'm breathing through trauma. And what I found is because I'm also breathing through and recovering from trauma and getting the necessary supports. And I think I had a lot of good things in place compared to many of the clients, because if they already don't have an intact psyche and they don't have healthy coping mechanisms already starting, and they don't have this, extended family network of support, then it puts them more at risk and being vulnerable. But because I really understand it, what I have learned is that this statement really does go a long way. Because when a person is breathing through particularly trauma, they really don't have the energy. It's just too stressful and it's too exhausting. And so what we have to do is we have to really make it a lot easier for them. And so what does that mean? Let's integrate music. In my culture, music is very, very essential. It's something that we do all the time. We use music because going back to slavery, for people of African descent, from slavery, people in slavery they weren't allowed to read. And so they used music as a way to communicate what they were going to do underground, all right, to escape enslavement. But these are just some songs that I picked up. Bashan Mitchell is a beautiful gospel song. I love gospel music, but it's called Beauty and Brokenness. And I love that song. When you get a chance, click it on as a YouTube. But I love that song is because it basically tells us that it's okay to be broken. Somehow we think that something is wrong to be broken. But to be broken it helps us to know that we are strong and that we have such resilience even in brokenness, because sometimes things can't be put back together completely. Say you break a mug, like I'm drinking this coffee. If I drop this coffee and it breaks on the ground, I have to throw it away. I just go get another mug. But there are some parts of ourselves that are going to be broken that we're not going to be able to put together, glue back together. And that's okay. There still is beauty. That's why I love Mosaic is the name of my company, because Mosaic represents a lot of broken color glass. And when you put it all together, it's beautiful. Another song you all might be familiar with is Rachel Platten, The Fight Song. I love that song because guess what? If you're feeling down and out, you put on that fight song, you're going to start hanging in there longer. And then I love LL Cool J's. This is taking me, you all way back. You might not even be familiar with LL Cool J's. If you play this clip to a client who has father absence, he says, all I ever wanted was a father. This is a good song that highlights adverse childhood experiences. If we had more time, I would click on the song, but unfortunately, I'm not going to be able to do that. So check it out when you get a chance. Some other outside the box creative arts And why it's important is because we get no training in expressive arts use. And I'm going to pause for a minute and see if people have questions in the chat. Where I just left the university that I directed programs, we actually had an expressive arts course, but most of us have not been trained in expressive arts. You don't have to be trained. You know what? Just start using it. Art, music. You can use coloring books. You can identify a song. When I was working with my supervisor, Joanna Franklin, at the time, and Joanna Franklin Robertson, who is one of our outstanding leaders, who's now deceased, she was amazing. She was my psychiatric the program I interned in supervisor, and I facilitated the spirituality groups modules. And so I started to identify songs to connect to a person's heart and to their spirit. And what I would do is I would identify a song, and then I would ask them for the upcoming group to bring a song that spoke to their heart, that spoke to whatever their struggle was, that spoke to, say, a past experience, or could give the language to what their emotional and cognitive processing isn't, eliciting on its own. Or you could use books or artwork to capture, what are you feeling right now? An example is with one of my adolescent clients, I was able to identify in the session that he had homicidal plans to kill his mother and his stepfather. And so I had to stop the session, go out and make a phone call to his parents, but also 911, because in the artwork, I saw the homicidal plan. And so that's an extreme example of what could happen when a person is really at high risk. But you could use some of these small, really creative initiatives right now. And you could even ask your client, choose a song or art or book that captures the vision of where you want to be in the future. So let me just see if you have any questions right now. I don't see anything so far in the chat. And I know we're going to have an opportunity at the end. Okay. So I'm going to just keep going. All right. So this is an example that I do want to play for you to hear from a gambler as an outside the box therapy example. I'm going to play this just for a couple of minutes, and hopefully, because this is a recorded session, you might be able to watch the full video, because this gambler is an African descent gambler who's going to share his experience, but it's about 11 minutes long and we won't have that much time.
This is Maurice. I am here to speak with you for a few minutes about gambling addiction. I was addicted to gambling in my early 20s to mid 20s. Well, that's when it really got bad. I mean, I've always gambled growing up. It wasn't something that we didn't do where I was raised. Everybody pretty much gambled some form or fashion. But growing up in the house, there were three generations, and pretty much in my upbringing, it was my great grandmother, my grandmother, and my mother, pretty much in the same household. Now I can remember as a little kid, we were not allowed to gamble with my grandmother, especially with my grandmother and my great grandmother around. We weren't even allowed to say, I bet you can't beat me in a race. Something as simple as that wasn't allowed with my grandmother. Now, with my uncles, I used to watch them gamble all the time. Not around my grandmother. So whenever she was not around, it was some gambling going on. Card games, dice games, some type of gambling. But anyway, as a kid, I got those mixed messages. But there was one thing that was always told to us as children. Don't do what I do what I say. And that came from my grandmother. Because even though she was really hard on us gambling, she played the lottery every day. Every day. Did not miss a day. And back then, they didn't do lottery on Sunday. So, but I believe if they did, my church-going grandma would have been playing the lottery on Sundays. So,
just move on, because in this, I want to tell you what Maurice did in this experience in the work. Maurice never sought gambling treatment. He never participated in Gamblers Anonymous. He is an example, and why I include him here is he's an example of the 97% of persons in our communities who are not accessing our wonderful evidence-based supports. And so it was years later that I was able to work with Maurice, not on the gambling, because actually he went to prison and he got out, and he shares his experience now as part of his recovery story, but he never participated in formal supports. But because I was getting him linked to mental health treatment, and he was very depressed, he experienced a lot of anxiety, the outside the box therapy included me addressing his racial and cultural invisibility as a Black man. Also the adverse childhood experiences, but I used a based focus emphasis highlighting you're a great dad, you're a great community member, you're a great mentor, you're kind, you're humble. Less focus on pathology, say gambling disorder and drug dealing and deficits. And I used an educational approach, and then was able to then link him to therapy. And I spent time talking about the issues related to not wanting to take even medication for his depression. Use real talk versus clinical talk. And so that's just a quick example of what you can do. And that leads me to the second strategy. Strategy 2 is what I learned from Dr. Edwin Nichols, who was with the National Institute of Mental Health. He was a cultural psychiatrist, and he did a workshop between 84 and 86 in my early years of being a counselor, professional counselor. And I never forgot what he said. Guess what he said? He said, earn the diagnosis. What did Dr. Nichols mean by that? What he meant was that, he said, clinicians, we do a lot in diagnosing everything, but often we diagnose so much, and the client, the family, the community member has nowhere near the internal resources or the external resources to succeed in all we're diagnosing. He said, when I'm thinking about this in terms of gambling, I think when a gambler demonstrates struggle, we interpret sometimes they're resistant, if they are struggling to implement some of the initiatives and interventions that we're trying to prescribe. But guess what I've learned? That depressed people are actually more realistic than non-depressed people, because guess what? They know what they can and can't do. It's like my depressed client who said to me, Debbie, this is too hard. She knew that this was really too hard for her. And I don't think that I really understood it quite at the time. She overdosed sadly and died. I didn't really understand that she really meant that this was too hard. She just didn't have the internal and external resources to do the work. She was in so much pain, she just wanted the pain to stop. And I don't know that I really understood that. So an illustrative case in terms of earn the diagnosis, the case of Carlos, I'll use as a gambler. He's a Mexican-American undocumented citizen. He arrived in the U.S. 5 years ago. He feels he has opportunities better here to support his family. He's stressed, he's depressed because he left his family and he hopes to bring them here one day. So guess what he starts to do? He starts gambling. He does manual labor. He's working like 2 to 3 jobs. He's living with 5 other people and they're sharing the rent. But because he's feeling disrespected at his work, because his boss could get him deported, he's even feeling more anxious and depressed. He increases $5 weekly purchases to $35. So now that's becoming a problem because he doesn't have enough money to pay his rent share. He's not even having enough money to send across to his homeland. And so one of his buddies is calling the helpline for help. So I want you to think about, what would you do if Carlos is your client? And if he was my client and he is our client, what I'm hoping we'll do is what Cheryl Richardson says: people heal when they feel heard. People heal when they feel heard. And what does that mean? That means that people of color and indigenous members, that we have to hear all of their experiences of racial trauma, their experiences of social injustice, their experiences of life just being hard to, sort of breathe through, because it's just too many things that are counting against us. And if we can gift them every time they come and listen to their heart, their mind, and their spirit, how can we support them with these experiences instead of maybe invalidating and saying, well, maybe you need to work harder? Because what we're saying now since last year is that COVID-19 pulled the curtains back open wide to see the lack of social justice. And so people are now saying enough is enough. And so what I would like you to do now is I want to think about, what are the opportunities that you can do as outside the box? And I have one intervention that you can use. This is an example of a client who called me for help when he was pulled over and detained while driving while Black. Traditional therapy is not going to address these social justice issues. And in reality, this client and his brother were not interested in therapy. They used me for crisis calls similar to calling your doctor when your stomach, you're throwing up constantly and you're having a temperature. What do I need to do? Traditional therapy would assess this call for help potentially as resistance if they weren't willing to commit to this long-term or ongoing therapy. But in these 2 Black men's lives, they already have their own local native resources that they feel works for them. And so what they would do is they would call me for help when there was a crisis, and when I helped them do the problem resolution for one visit, then they were off and on their way. So it's almost like a counselor on call kind of support. That's an outside the box. I mean, lawyers will provide themselves on retainers. We probably need to rethink mental health treatment also, to say that for some clients that are not going to commit to this long-term or ongoing, more long-term therapy, what can we provide that can still give them some support? So what I say about social justice and racial trauma is I would want us as an outside the box technique to stop doing a dance around it and do a dance with our clients. Let me say that again. Let's stop doing a dance around the racial trauma or the social injustice experiences and instead dance with them. Let them lead the dance and tell us about it. Because basically, clients see these experiences and the question is, do we see you? This says you see me. What we're hoping is that you're going to see them. So this is a racial trauma and coping healing brochure that Dr. Lillian Comas Diaz has put together with her research team. And it's a really great visual. You could hang this in your visual virtual office. If you're doing telehealth, I would recommend, if you are reopening, I would get these blown up and I would hang these up around the agency or your private practice, or if you're doing community outreach to community stakeholders, past pass it and share them. Have them as brochures, just like we have brochures on depression, anxiety, trauma. I would have these around in the bathrooms, in the wait area. And that way people can become familiar with what are the signs and symptoms of racial trauma. We don't have time today because that's I could do a whole workshop on that. But the reality, as I said, is that unfortunately, some people have not had sufficient training on racial trauma. And so you might be afraid to do it. I encourage you to get more training, and I have some books and resources for you as well. So, I'm sorry. This is a case of Martin. And this is, I called this case Martin, but this is actually the same client that was willing to share his name in the vignette. He did that vignette, he did that video recording just for me for the trainings that I'm doing on racial trauma, and sharing his story as a gambler in recovery, but also a man who's breathing through. So when you read this, you'll get more of his story, but really it talks about all the different ways that he was invisible. And so another technique that I would use is integrate cultural literature and explore with the client, like I would explore with Maurice, or is referred to as Martin in the case scenario, from The Invisible Man, Ralph Ellison. He says, I'm an invisible man. No, I'm not a spook like those who haunted Edgar Allan Poe, nor am I one of your Hollywood movie ectoplasms. I'm a man of substance, of flesh and bone, fiber and liquids, and I might even be said to possess a mind. I am invisible. Understand simply because people refuse to see me. So this would be a good way to incorporate this anatomy of invisibility. And Ralph Ellison is just one author, but there are other person of color authors that you can check out and incorporate literature to help your clients. This is another book hot off the press that I'm showing because this is authored by an African descent author, S.L. Hughes. She titles it, Keep Your Pecker in Your Pants. Many of our gamblers are recovering from rape, sexual assault, sexual violation. And this Black author shares her own lived experience being raped by her stepfather, who was also a pastor. Imagine that. And we know that that's happened too many times. And if that isn't something that's going to disrupt your faith identity and your spiritual identity, which can get in the way of, like, say, a gambler who we have research that shows they have all these experiences, many of them, of trauma, including sexual trauma. And so we don't understand oftentimes why they can't do step one, because that also has disrupted their relationship with the higher power. And they don't feel that they can trust their higher power because where was God when I was being raped? So that's one example that I've heard from clients. This is some other work that I'm sharing with you. Another good resource, Racial Battle Fatigue, and I'm including some probes that you can use. Sheila Rowe has published this book in 2020, and she talks about racial trauma, just like Dr. Lillian Comas-Diaz has, being similar to PTSD. And then these are some probes that you can use. Like if your client who's struggling with racial battle fatigue, you could ask them, how has this racial battle fatigue affected your life? How has your life been silenced? She has probes on rage. Are you struggling with anger or rage? Are you afraid or are you highly anxious as a result? What kind of support do you need? What lament do you have? Are you asking God or your higher power to reveal the source of any hidden shame? And how about addiction? I love this statement, which was anonymous. Before you can break out of prison, you must realize you are locked up. Are your gifts and abilities locked up because of racial trauma or social injustice violations? Okay, so these are just some, and there's some others, and this is a wonderful book. She also includes a racial trauma genogram. So this is another outside the box intervention. We have learned how to do family genograms. Well, guess what? We can do a genogram to look at the history of racial trauma. So I want to give an opportunity because we're not going to have enough time. I do have like some other examples for you. You'll have the slides. You know, I give you some clinical cases that you can apply the techniques to. I also give you podcasts like Healing Racial Trauma. You can assign your client as an outside the box exercise to listen to this podcast, and then you can process it with the client. You can listen to it in a session if you're concerned that your client doesn't have the external resources to support them fully. And you can maybe incorporate this in your group therapy. So there are a couple of podcasts that you can do. Here's a podcast by the author of a racial trauma reflection guide. This is a great book. I would highly recommend it. And there's a podcast that goes along with it. And then my closeout is just expand therapy and mental health healing to 95%, not just to 3 to 5%. Prevention, prevention, prevention. Dr. Yen, who is an Asian descent psychologist, says Asians are not going to seek treatment. You have to focus more on prevention. Also want to encourage you to provide free community psychoeducation, because again, they're not going to jump at coming in for mental health traditional treatment, but if you offer Facebook Live education, they may get linked to the gambler treatment and the 1-800-GAMBLER helpline more openly, because you're now providing a face to the concerns and providing them some free education. And then what I really recommend is commit to year-round community public health messages on social media. If you can't do it, get an intern who can do it. And so the next slides basically just provide you more materials, more adjunctive supports. I have, some cultural resources here. This is a photo essay. This is a great book by Dr. Sandra Adele, written by an African descent gambler in good recovery now, Confessions of a Slot Machine Queen. Here's some resources for Asians, descent members, Asian Mental Health Collective, just to really get around the stigma. The Asian Pride Project is for LGBTQ members. And then this is a really good resource for Native American healing and mental health. And so I know that's a lot, and I'm going to stop and see if you have questions or you're in need of clarification. So thank you. Okay. Thank you for valuable information. Please tell me we will be able to have access to the PowerPoint, or I missed a little bit and would love to view the resources. Absolutely. So I'm going to share this as soon as I exit, and then they'll send it out to you all. Thank you very much. And thank you, Evergreen, and appreciate all the wonderful work that the Evergreen Council is doing some amazing work. Thank you. Thank you, everybody. Have a great day.
Thanks, you too.
You're welcome. Bye-bye.
Bye.